So antimicrobials are some compounds which have some activity against the microbes which are attributed to causing human diseases. I think you have been already talked about the history and how various pathogens were discovered. Now let us look at some of the methods in which diseases were treated before the discovery of antibiotics or antimicrobials. A few examples would be like letting the blood flow or using mercury fumigation. Some of the more rare methods which are still being reinvented and now reinstated would include use of maggots, especially in chronic wound healing, use of honey and silver. Okay, so nowadays silver being used as a nanoparticle. If we look back, the current treatment of malaria, it also derived from, that is the quinine, was derived from the bark of the cinchona tree. And similarly, before the advent of antibiotics, immunotherapy was one of the main modalities of treating infectious diseases, that is, using immunoglobulins. But the breakthrough came in the 19th century, early part of the 19th century, by this man. Can you recognize this person? Anyone? So this is the picture of Alexander Fleming. So what did he discover and how it changed the outlook of the medical sciences? Well, he went on a leave, and in his laboratory, after he came back, he saw that culture plates which grew Staphylococcus have been inhibited by the growth of a fungi. That fungi was later named as Penicillium. So he hypothesized that this fungi produces a certain chemical which inhibited the growth of the bacteria, and hence it was called as penicillin. However, extracting the penicillin from this fungi was not so easy. It took another 20 to 30 years, so that extraction was perfected, and then eventually it was used on the human body. One of the most notable efficacy that was seen with penicillin was during the First and Second World War, where most of the infections were being able to be treated with the use of penicillin. Following that, there was a rapid surge of discovery of new and new molecules from various sources, which showed some kind of antimicrobial effect on various bacteria. And over the period of the last century, we can see we have a huge armamentarium of antibiotics that we can use for various infections. Now, what are the sources? The common sources that can be attributed are a group of bacteria called actinomycetes. Although they are bacteria, some of the behavior resembles that of a fungi, or other bacteria and other fungi. Synthetic development has also been seen. Some of the molecules have been called as synthetic antibiotics. So thus antibiotics were discovered and most of the infections were being treated. To such an extent, in the 1970s to 1980s, the dictum was, in any case of infections, treat the patient with antibiotics. The goal was to kill all pathogens. Eventually, what came up was antibiotic resistance. Now, before going to antibacterial drugs, we have antipathogenic drugs. If any drug acts on bacteria, we call it as antibiotic. If it acts on fungi, we call it as antiparasitic, antifungals, and antivirals. So whatever organism they are acting on, we call them by that name. A group of bacteria called as mycobacteria are particularly very difficult to treat. So there is some set of antibiotics which are used to treat mycobacterial infections. They are again classified based on whether the drug is able to kill the bacteria immediately or inhibit the growth. If the antibiotic is able to kill the bacteria, it is called as cidal. Cidal means to kill. And if it inhibits the growth of the bacteria, we call it as static. Hence, it is called as bacteriostatic. Okay. Now, in today's class, I will give you a brief overview of the various antibiotics. And before giving the brief overview, let us look at this structure. This is the structure of a bacteria. What does it contains? I have already told you in the morphology class. On the outside, you can see a thick layer that is called the cell wall. And then we have the cell membrane, and we have this. What is this? This one? It is the nucleus. What does the nucleus do? There are two main important functions. One is new DNA replication and another is protein synthesis. For protein synthesis, we have another molecule. What are these called molecules called as? Ribosomes. Okay. And various other metabolic pathways that goes on in the bacteria. So how does this antibiotic act? It will act by inhibiting one of these following. So let us have a look. The first one is drugs which act on the cell wall. Now this group of antibiotics are very effective. Why they are effective? Because cell wall is a constituent of a prokaryote cell, but is not found in eukaryote. So if any drug which acts on the cell wall will specifically act on the bacterial wall only. It will have almost no effect on the human cells. Furthermore, you have already understood that the cell wall, what is the function of the cell wall? It prevents osmolysis. So if in any bacteria the cell wall is damaged, what will happen? Even without any kind of intervention, the bacterium will undergo osmolysis. Okay. So this is the reason why any agent which acts on the cell wall is very effective. So what are the groups of antibiotics which act on the cell wall? We have the beta-lactam group of antibiotics and the glycopeptides. Next is we can target the nucleic acid synthesis. Groups of antibiotics like the quinolones and the rifampicins, they target the nucleic acid synthesis. Again, I think we have already learned about this folate acid synthesis. These group of antibiotics are also called as anti-metabolites. They will compete with the normal metabolite of the bacterial cell and thereby inhibiting the metabolism. Certain groups of antibiotics will then target the protein synthesis. Either it will act on the, have you forgotten protein synthesis? What are the requirements of protein synthesis? We need ribosomes and rRNA and tRNA, right? So some set of antibiotics will act on the ribosomes. Now keep in mind the ribosomes are different in case of prokaryotes and in case of eukaryote. In the prokaryotes, we have the 30S and the 50S rRNA. Ribosomes. Then the last is some antibiotics will have direct effect on the cell membrane. Now this set of antibiotics, even though they act on the cell membrane, remember the cell membrane structure is almost similar to the human cells also. So these group of antibiotics will have a profound effect on the human cells also, which are commonly called as the adverse effects of the drug. Now let us look at these groups one by one. First is which act on the cell wall biosynthesis. Now what is the constituent of the cell wall, predominant constituent of the cell wall? Peptidoglycan. So what is peptidoglycan composed of? It is a cross-linked chains of N-acetylmuramic acid and N-acetyl. Now these two molecules are transported alternatively to form a cross-linked chain. So there are some proteins which will enable this movement. Now initially what penicillin was found, when the mechanism of penicillin was found out, the penicillin used to bind with certain proteins, hence they are also called as penicillin binding protein. Okay. Later on it was found out that these proteins actually was very instrumental in forming the cross-linking chain of NAM and NAG in the peptidoglycan. If that is inhibited, what will happen? Peptidoglycan synthesis will be inhibited. Now, please keep in mind, it is not a, the peptidoglycan is a dynamic structure. Some part is being degraded and some part is being synthesized. So, synthesis and degradation goes on continuously. It's not a static structure. So, whenever the synthesis is inhibited, what will happen? The peptidoglycan will lose its layer and eventually the cell wall will be destroyed. Now, if you look, these antibiotics are called as beta-lactam antibiotics. Okay. Among them, we have penicillin, cephalosporins, carbapenems, and monobactams. Now, why are they called beta-lactams? Because if you look at the structure of all the groups of antibiotics, we have a particular ring structure. This ring is common in all of them because this is the structure which binds to the penicillin binding protein. So, when we say beta-lactam antibiotics, that means whatever may be the side chain, it will have a beta-lactam ring which will bind to the penicillin binding protein. Understood? Some modifications will be there based on the type of the drug. The penicillin will have some different structure from the cephalosporin, which will have a slightly different structure from the carbapenems. Okay, understood? Now let us look at penicillins. So initially, recall the story about Alexander Fleming. The initial penicillin that was discovered is called as penicillin. That penicillin was acid labile, hence it could not be given orally. It is called as penicillin G. Slight modification was done to make it acid stable and it was called as penicillin V. These were the first primitive antibiotics. Later on, amino groups were added to this structure and we have got ampicillin and amoxicillin. Those were more acid stable, hence oral prescription can be done. These are called as the aminopenicillins. Now, penicillins and aminopenicillins have a wide range of activity. It can also affect the gram positives and the gram negatives. Next, it was seen that some bacteria, especially Staphylococcus, started producing an enzyme called as penicillinase. As the name suggests, this enzyme started degrading the penicillin group itself, that is the beta-lactam ring. This enzyme used to target the beta-lactam ring. Okay. So what was done? If you look at this, there is an R group. R group means this group can be substituted by another molecule. So this R group was substituted to make what are known as penicillinase resistant penicillin. That means some penicillins which will not be degraded by penicillinase. These include drugs like oxacillin, flucloxacillin, methicillin and nafcillin. Okay. All was fine. Next, we encountered another particular organism that produces a green colored pus on wounds. That particular organism is called as Pseudomonas. Now, Pseudomonas is a gram-negative bacteria. So, any molecule which has to enter into the gram-negative bacteria must enter through small holes in the cell membrane. Those are called as porine channels. Problem with Pseudomonas was that these porine channels were very small, very less in number. And these antibiotics which have heavy group fail to enter into the cell. So again the penicillin was modified by adding carboxyl group or urido group to make what is called as carboxypenicillins or uridopenicillins. So these penicillins have very thin structure, small structure, and it can easily enter through the porine channels. Hence they have what we call as anti-pseudomonal activity. But again, when you make the structure of the penicillin slimmer, it will be more the beta-lactam ring will be more easily exposed. Hence, if you look at the drug combination that is given, along with these penicillins, we give something called as beta-lactamase inhibitors. Have you heard about that? Whenever amoxicillin is given, it is given with clavulanic acid. Have you seen? So what is clavulanic acid? This is a beta-lactamase inhibitor. This molecule will bind to the beta-lactam, that is the penicillin, and it will get destroyed, protecting the penicillin molecule. Hence, you will see all the carboxy and ureopenicillins are given in combination with beta-lactamase inhibitor. Okay. Later on, from another, okay. Now, this is how penicillins were discovered, but as of today, we can classify penicillin based on various ways. The first is based on the source, whether it is naturally occurring or it is semi-synthetic. Semi-synthetic means when the R group is replaced by various molecules, or based on the route of administration. That is whether we can use it orally or parenterally. Again, based on the spectrum of activity, we can have a narrow spectrum or a broad spectrum or extended spectrum. Again, based on the resistance to enzymes, we can have penicillins which are resistant and which are labile. Okay. So this was all well till then. Next, it was found out that a particular strain of Staphylococcus aureus was found to be resistant to most of the penicillins. So they started substituting the molecule and found out a particular penicillin called as methicillin. The methicillin was effective in most of the cases, but this particular Staphylococcus aureus strain was even resistant to methicillin. So this kind of strain was called as methicillin resistant Staphylococcus aureus, or also called as MRSA. So what they eventually found out, that the reason was not enzymes which were able to degrade methicillin, but rather there is a structural change of the penicillin binding protein itself. The bacteria has been able to change the structure of the penicillin binding protein. Hence, this beta-lactam ring no longer attaches to the penicillin binding protein. Have you understood till now? So, whenever we do encounter a strain which is MRSA, that is methicillin resistant Staphylococcus aureus, keep in mind none of the beta-lactam drugs will be effective. Okay, I'll come to that later. Now, next group of beta-lactam drugs which were discovered are called as the cephalosporins. As of today, we have 4 generations or 5 generations of cephalosporins. Now, if we look at the coverage of the cephalosporins, the first generation cephalosporins were more effective in case of gram-positive organisms. And as we move towards the 4th generation cephalosporin, the coverage is almost exclusively to the gram-negative organisms. And I've already told you the MRSAs. So the 5th generation cephalosporin have anti-MRSA activity. This cephalosporin will bind to other sites other than the penicillin binding protein beta-lactam binding site and will have anti-MRSA effect. Those are called as the anti-MRSA cephalosporins. Okay. The next, again, as more and more antibiotics was used upon, the gram-negative organisms, especially the Enterobacteriaceae, were found out to be resistant to most of the drugs, including cephalosporins. So the next type of beta-lactam drug that was used are called as Carbapenems. We have 3 groups of Carbapenems, and if you look, there is in the group 2, that is imipenem, meropenem, they have activity against Pseudomonas. Okay. Another group of beta-lactams are called as monobactams. They have a very small range of action. However, they are now more currently used, especially in case of ESBLs and the CI. ESBLs means extended spectrum beta-lactam producers or carbapenem resistant organisms. Okay. So I will not be discussing this today. The next group of antibiotics which act on the cell wall are the glyco and the lipopeptides. Now, as the name suggests, these are glyco and lipopeptides, means they have a polysaccharide moiety with a peptide molecule and the lipid moiety with a peptide molecule. They will inhibit the peptidoglycan synthesis in the late stages of the cell wall synthesis. These include vancomycin, teicoplanin, ramoplanin. Because their mode of action is different from the beta-lactam, hence these drugs are very commonly used in case of MRSA infections. So these were the drugs which act on the cell wall. Next group of drugs are the drugs which act on the protein synthesis. First group is aminoglycoside. It acts on the 30S subunit of the ribosome. This would include drugs like gentamicins, kanamycins, neomycins and streptomycins and their derivatives. Next group of drug would include the tetracycline group of drug, which would include three generations like tetracycline, chlortetracycline, doxycycline, tigecycline, etc. And finally, and then we have macrolides. Macrolides also have many generations like synthetic or semi-synthetic and naturally occurring. These macrolides inhibit the 50S subunit of the ribosome. Other drugs which act on the ribosomes would include lincosamides. They have similar like clindamycin, which act on similarly to macrolides on the 50S RNA, chloramphenicol and oxazolidines like linezolid. Next group of drugs are the very important group of drugs which act on the nucleic acid synthesis. These would include the quinolones. They act by inhibiting the topoisomerase. And we have rifampicin, that is very, I think you already have heard about rifampicin. It's an antitubercular drug. They act by inhibiting the DNA transcription. Among the quinolones, we have 4 generations of quinolones starting from nalidixic acid to other drugs like second generation like ciprofloxacin, norfloxacin, ofloxacin and till 4th generation like moxi or gemifloxacin. In the antimetabolite group of drug, we have very commonly known as the sulfamethoxazole, which inhibit the folic acid synthesis by competitively inhibiting them. And finally, we have drugs which act on the cell membrane. These would include lipopeptides like daptomycin. They form meshes and interact with the cell membrane to cause leakage in the cell membrane. Or we have polymyxins or colistins. They basically have a detergent-like effect and they remove the lipid part in the cell membrane, thereby destroying the cells. Now again, I will remind you, because they act on the cell membrane, they will have some serious adverse effect when we use in the human body. So that is the comprehensive overview of the various antibiotics that we use today. Okay. However, with the use of the antibiotics, we have now have a situation where many drugs are being resistant by this bacteria. So antibiotic resistance can be affected by various mechanisms. First type of mechanism is called as the efflux pumps. So what are efflux pumps? A bacteria needs something from the environment and it needs to excrete its own metabolic waste into the environment. So there are some specific pumps which will efflux out whatever that is not required within the bacterial cell. Some bacteria, by mutation, they develop some efflux pumps which can move the antibiotic molecule from inside the cell to the outside. As the number of these efflux pumps increase, more and more antibiotic molecules will be thrown out from the bacterial cell wall. This kind of resistance is very commonly seen with fluoroquinolones, rifampicins and beta-lactams. The next type is immunity or bypass. I have already told you sulfamethoxazole is a competitive inhibitor in the folic acid synthesis. some bacteria develop a way to bypass that pathway and start generating folic acid by a different pathway. This type of resistance is called as bypass mechanism. Or the bacteria may alter the target of the molecule. Like I have already told you, in case of MRSA, the penicillin binding protein is altered. If that binding protein is altered, the antibiotic molecule will no longer be effective. This kind of target modification can be seen in case of fluoroquinolones, vancomycins, daptomycins, and even in case of MRSAs. And finally, a very important type of resistance is seen where the bacteria start producing enzymes which can degrade the bacteria. It can degrade the antibiotic molecule. Examples would be beta-lactamases, which degrade beta-lactam antibiotics. Okay. They are again classified based on what kind of molecule it can degrade. If it can degrade only penicillin, we call them as penicillinases. If it can degrade cephalosporins, we call them as cephalosporins. Similarly, if it can degrade carbapenems, we call them as carbapenems. Okay. And other antibiotics would include aminoglycosides. Now, why understanding this resistance is important? Why is it important to understand the resistance? Exactly. If a particular antibiotic is not effective in the laboratory conditions, most probably it will not be effective in the body. So there will be what we call as therapeutic failure. Now, to avoid that, we must understand what we call as antibiotic therapy. That means we should know how to use the antibiotics. The first step is we must understand what are the types of treatment in which antibiotics are used. The first type of treatment is called as empirical therapy. Empirical also means a blanket therapy. This is given when we do not know what is the exact cause of the disease in the patient, caused by which organism, and its response. We don't know. What we do is, it is a treatment that is given on experience without precise knowledge of the cause. That is called as empirical therapy. So it is generally started as early as possible. Now, you tell me, is empirical therapy enough? No, because we don't know the cause. We don't know what is the organism, whether it is susceptible to that particular antibiotic or not. So what we need to do is, we need to give a proper therapy, proper antibiotic. So here comes the next, that is the preemptive therapy. So from empirical, we need to preemptive therapy. What is preemptive therapy? Over here, based on the patient's either clinical finding, imaging, or any serological finding. If we get some kind of indication, we can modify our antibiotic therapy. For example, there is a patient who has a wound infection. Okay, suppose was involved in a road traffic accident, there is a wound infection, and he has come to you. And the patient is complaining about pain and swelling. You don't know what is the cause of the organism which is infected. So what you have given? You have given a beta-lactam antibiotics. Suppose you have given amoxicillin, because that antibiotic is commonly given and is effective in most cases. Next day, when you visit the patient again, you observe that the open wound, has started green colored pus. So from that you can derive that this green colored pus is commonly seen in case of Pseudomonas infections. And then you have to recall that the antibiotic that you have given may not be effective in case of Pseudomonas. So what you need to do? You need to change the antibiotic. So this is called as preemptive therapy. That indication could be a clinical, it could be an imaging, or it could be any other ancillary evidence. So whenever you get any kind of evidence which may indicate to a particular organism or a particular disease, and you change the antibiotics, it is called as preemptive therapy. Understood? Next, what you need to do? you need to take the pus and send it for laboratory examination. What you want to know? What is the exact organism that is causing the infection? And what are the drugs which may be used in this case? Right? After getting the results, now suppose you get the report from the laboratory that this is caused by an organism that is Pseudomonas, and suppose it is sensitive to a particular cephalosporin. So what you need to do? You need to change the antibiotic again and give that specific antibiotic. Okay, this is called as definitive therapy. When we know the exact organism causing the infection and its susceptibility pattern, that is called as definitive therapy. So the role of antibiotic therapy would be to move from empirical to definitive therapy. Have you understood this point? Okay. So to get the definitive therapy, we must get the laboratory report or the susceptibility report, right? So what is the goal of susceptibility testing? The primary goal of susceptibility testing is to provide the antibiogram based on which we can start the treatment. What is antibiogram? Antibiogram is, have you seen any susceptibility report? There are a group of antibiotics which are tested in the laboratory against that particular organism to know whether it is sensitive or resistant. That is called as antibiogram. The next step is to monitor the effectiveness of therapy. Why this is important? Suppose based on this report, you have started an anti-pseudomonal drug and you are giving the patient high dose of antibiotics and you have stopped monitoring. What will happen? Even during therapy, the bacterium may become resistant and there could be therapeutic failure. Then you will come with the report to the laboratory, say, I have seen this report and according to the report I have treated the patient, but still there is therapeutic failure. So the goal is not only to initiate the therapy, but also to monitor the therapy. Now look at this chart. There are some steps that which predict the effectiveness of therapy, and some it monitors the effectiveness of therapy. So when we say predict the effectiveness of therapy, that means we are talking about the susceptibility report. Now keep in mind that test is being done in the laboratory conditions. It can only predict the effectiveness in the patient. It cannot state the effectiveness. Have you understood this point? Because that test is done in the laboratory, that is in vitro. We can only predict based on that report. We cannot be absolutely certain that if a drug is effective in vitro, it will be effective in vivo, and vice versa. Many a times it is seen that a drug is seen resistance in the laboratory, but in the patient it is effective. So it can only predict. Now, all the testing that is done is based on some standards. Okay. So there are many standards I have just written so that you get acquainted with. A particular common standard that is used is the CLSI standards. Other than that, various countries like the British, German and the French, they have their own standards. As far as my knowledge is concerned, we don't have an Indian standard, we follow the CLSI standard. Now, tests that are done to predict effectiveness of therapy. The first is called as disk diffusion method. So what we do in this method is we culture the bacteria on a petri plate, okay, containing the media, and we put, what are these? These are paper discs which contain antibiotics. And the amount of drug that is put in every disc is based on the standard therapy that is given to human being. Okay. So there is a standard therapy based on which the concentration of drugs is put in this disc, and after incubation, I think you can appreciate there is a zone of inhibition. This zone is measured based on the MIC, which are again given by the CLSI guidelines. If the zone is big over a certain range, we call it as susceptible, and if it is smaller than a certain range, we call it as resistant. Now when we say susceptible and resistant, that means as far as the standard dosing is concerned, right? I think in pharmacology we have learned something about standard dosing. So standard dosing is for whom? For whom? For the ideal patient with a normal volume of distribution, normal renal clearance, normal weight. Okay. But these parameters can change. I'll come to it later. The next method is to get what is called as MIC, or the minimum inhibitory concentration. Minimum inhibitory concentration means the minimum amount of drug which inhibits the growth of the microorganism. It inhibits the growth. It may not kill it, but it will not allow it to reproduce. So this, how is it done? The bacteria is grown in this microtiter plate, and the antibiotics will have a decreasing concentration. At some point, we will find there is no growth. That is the MIC. Obviously, the MIC, this kind of testing is extremely laborious. We have to dilute each and every drug concentration and put, for a single organism testing, we need to do a lot of work. A combined method that can be done is called as the E-test or epsilometry test, or also called as gradient diffusion. What is done over here? The organism is again cultured on a petri plate containing media, and you can see this strip. Now this strip contains the antibiotic in a decreasing concentration. After inoculation, you can see a zone of inhibition, and if you look closely, this zone of inhibition merges at this point. So this point will give us the MIC. So this is much easier method to be done in the laboratory. Alternatively, we can use automated systems. Now what this automated system is done, they are doing, they monitor the growth curve of the bacteria. Recall in the morphology class I have already told you about the growth curve. There is a lag phase, then log phase. So this machine detects the growth phase. If the growth is inhibited, that is the MIC. Advantage of this machine is human labor is very less. Okay. These tests will predict the how we are going to initiate the antibiotic therapy. But why do we need to monitor the antibiotic therapy? Because of antibiotic resistance. Now, I have already told you one of the main mechanism of resistance is by producing enzymes which can degrade antibiotics. What are enzymes? These are proteins. So if it is a protein, there must be a genetic code present within the bacterial DNA, which ultimately is transcribed to that protein. If we test those genetic material which encode for the resistance enzyme, we can detect whether the resistance is present or not. That is done by the molecular testing, where we detect those particular set of genes for enzymes which degrade antibiotics. Okay. Please keep in mind, mere presence of the gene may not result in production. The next what we can do is, we can get what is the MBC. What is MBC? Minimum bactericidal concentration. Just try to concentrate over here. In this test tube, we have a serial dilution of antibiotics. Okay. This has the highest concentration. This has no drug. And in all of the test tube, I have put a similar concentration of bacteria. After incubation, what I have started to do is, I have taken subcultures from each tube. What will happen? The tube which contains no drug, we have the maximum growth, and the tube which contains maximum drug will have no growth. But if we go from right to left, what we will see, at some concentration, the bacteria is still viable, but the number is not increasing. We call it as MIC, or minimum inhibitory concentration. But beyond that, we can find the bacteria is still growing. So that is not cidal concentration. At, let us say, 4 microgram, after subculture, we have found there is no bacterial growth. That means the cidal concentration is 4 and the inhibitory concentration is 1. Now, why this is important? When a normal human being is infected with an organism, the human body has its own set of defenses to fight against the organism, right? When the human body cannot contain the infection, we have the disease. Have you understood this? If your body can contain the infection, you won't have the disease, right? When your body is overwhelmed by the multiplication of the bacteria, then we have the disease. Now, when I give any antibiotic, what happens? The antibiotic rapidly kills the bacteria. Their number goes down. They are not killed in all, but their number goes down. Whenever the number goes down, the body can now fight against the bacteria and you heal. We heal. Now, let us take an example of a patient whose body cannot fight infections. Can you think of any person? Bolo? Very good. Whose immune system has already been destroyed by any other factor. It could be by any infections like HIV. It could be because of a malignancy. It could be iatrogenic. For example, for treatment of any malignancy, we are giving chemotherapeutic drugs or steroids. Steroids can suppress your immunity. At this stage, what will happen? Even if we give antibiotic, the body cannot fight. So we need to give the antibiotic at a dose that is higher than the MIC. Have you understood this point? Okay. Other method we can take the serum of the patient and test for the concentration of the antibiotic itself. However, it is extremely tedious and generally done only for research purposes. But what we can do is we can take the patient serum sample and check the exact levels of the antibiotics. Now this is a chart. Suppose a patient is being given antibiotic at repeated doses. So whenever the patient's antibiotic is given antibiotic, what happens? The concentration of antibiotic rises sharply to form a peak, and slowly the drug will be removed from the body to a lowest point that is called as the trough. Why this measurement is important? So that we can maintain a certain concentration throughout the therapy. How can we maintain? By modifying the dose or duration of giving the antibiotic. Okay. And the last part is we can test various drugs which have what we call as synergy. Synergy means, I'll give you an example. For enterococcus, it is commonly said give beta-lactam drugs like penicillins along with aminoglycosides. Now, enterococcus have a very thick cell wall. Beta-lactams like penicillin cannot penetrate it, will be resistant. Aminoglycoside may also be resistant. But when we give it in combination, what happens is, if a small molecule like gentamicin, not a small molecule, if one or two molecules of gentamicin enters into the cell, what will it do? It will inhibit the protein synthesis. If protein synthesis is inhibited, then peptidoglycan synthesis is inhibited. Now, when peptidoglycan synthesis is inhibited, the permeability of penicillin increases and it further destroys the cell wall and eventually the bacterium dies. So, this is a synergistic effect. So, we can give two or more drugs with each other which have a synergistic activity. Okay. Because we follow CLSI in India, CLSI have categorized drugs into few groups. The first group is called Group A drug, in which for any organism the primary antibiotics which are tested are called Group A. Group B are also primarily tested but not routinely reported. They are reported only if the primary tested antibiotics show resistance. Group C is supplemental testing. If both Group A and Group B groups comes resistant, we test for the Group C. Next group is U. U group is for only urinary samples. And others means others drugs which are kept for reserved. And finally, we have the investigational drug that is not routinely done in the diagnostic purposes, only for the research purposes. So whenever you are encountering an antibiotic sensitivity report, you will encounter these three groups, that is A, B, C and U. Okay. Now what is the report that is given? The report that is given will come out in these three. The first is susceptible. When an in vitro report is susceptible, what does it mean? It means when you are giving the standard dosing is enough for treatment. What is susceptible dose dependent? That means you have to alter the standard dosing. Either give the drug more frequently or at a higher concentration. This is called as susceptibility dependent on the dosing. Next is intermediate. What is intermediate? Intermediate means the drug at a normal dose will act only on certain areas. For example, some antibiotics will get concentrated in the urinary bladder. বেশি হয়ে যাচ্ছে নাকি সব একদম চুপচাপ try to understand. Intermediate means say some drugs will get concentrated through the kidneys into the urinary bladder. So if the patient is having a cystitis, that is infection in the bladder, the antibiotic will be effective. But if he is having pyelonephritis, that means the infection is in kidney and in the blood vessels, the drug may not be effective. Okay, so whenever you encounter an intermediate report, you have to understand where the infection is and what is the drug you are choosing. Resistant is obviously, that means at the standard dosing the drug will not be effective. And last is non-susceptible. There are few organisms for which a particular antibiotic have only a susceptibility breakpoint, not the resistant breakpoint. For example, let us say an organism which has a susceptibility for cholesterol as 2. So any strain which has a susceptibility less than 2, we can say susceptible. But we don't know the resistance breakpoint. And the MIC comes as more than 2. What will you report is that non-susceptible. We cannot say it is resistant, but it is non-susceptible. Now why MIC is important? These are the three main factors which define the therapy. One are the antibiotic molecule itself. The next would be the microbial species, whether it is producing resistant enzymes, etc. or not, and the clinical situations. So what are these? These factors are very important. Antibiotic itself I will come to it later. Then microbial species depending on the enzymes that are produced, and the clinical scenario, whether the patient is in ICU, whether there is a renal compromise or not, whether the patient is elderly, immune compromised or not. These all factors will come in when you have to predict the response of the antibiotic therapy. So this should be governed by PKPD data. What is PKPD? পড়ানো হয়েছে তো ফার্মাকোলজিতে? What is pharmacokinetics and what is pharmacodynamics? Exactly. So for appropriate treatment, we need to know the PKPD data of the antibiotic. We need to know the microbial species, the particular type of tissue infection, and the patient's own parameters. So these are the things that you should know before initiating a definitive therapy. What is this chart? Pharmacology the porno. What is this chart? Okay. Suppose in a patient I am given an injection of a drug. The concentration of the drug rise rapidly and then slowly it will be excreted out. When it reaches the maximum concentration, it is called as the Cmax, maximum concentration. And if we trace the MIC concentration over here, we will get a time period from here to here where the concentration of the drug within the serum of the patient is higher than the MIC. This is called as T more than MIC. Another thing is this area under the curve, that is from Cmax and above MIC. This is called the area under the curve. And next part is this drug is eliminated. What is T half? When half of the drug is eliminated, it is called as the T half. This is for every drug, not only for antibiotic, for every drug. Now, why is it important? Because it will tell us how we should dose. Because it will either have a concentration dependent kinetics or a time dependent kinetics. For some drugs, we need to maintain this time above MIC for a prolonged period of time. And for some drugs, the peak concentration matters. So, how it will modify the dose? For drugs where we need time above MIC, we need to give dosing at repeated intervals so that the concentration remains above the MIC. For drugs where concentration matters, we need to give a higher loading dose so that the peak concentration reaches the high. Okay. Some groups like over here, look, the beta-lactams, they have time dependent action. That means as long as you can give at a particular dose in a constant level, the drug will be effective. And for some drugs like aminoglycosides and quinolones, the peak concentration is very important. These will again come when determining the losing dose and the maintaining dose. I am just touching these points. You will learn more depth in pharmacology. Last point is WHO classification of AWARE. What is AWARE classification? WHO has classified the drug into 3 groups: access, watch and reserve. AWARE is the acronym of access, watch and reserve. So what is this? Some drugs which have access to easily, those are called access group. Some drugs are kept as a watch. They should be used only in case of resistant cases, and some drugs are kept in reserve group, should be used in severe cases only. And WHO, if you go to, there are other drugs, investigational drugs, if you go to the WHO website, you can find the names of all the antibiotics over there. Each have been classified into either access, A for access, W for watch and R for reserve. And last point that I want to highlight is, we have talked about antibiotics, we have talked about the resistance, we have talked about how to initiate and monitor antibiotic therapy. Last point is how to monitor use of antibiotics in the hospital or the institute for prevention of resistance. The goal is to use the right antibiotic to the right patient at the right time, at the right dose, at the right route. Few things we as a doctors need to practice. First is prescribe only when indicated. Most of the cases of upper respiratory tract infections are of viral causes. Do not give antibiotics in case of viral infections. Next, make a habit or a culture of cultures. Don't be too overconfident about the type of the infection you are diagnosing clinically. If you think it needs a microbiological evaluation, go for the cultures. Okay? Because ultimately you need to give the patient the definitive therapy. However good your clinical acumen are, you are giving empirical therapy only. So make a habit of or a culture of sending cultures. Then dial down the empirical therapy based on the local antibiogram and go for targeted or pathogen therapy. Suppose in a patient, the organism becomes more and more resistant. So what we need to use? We need to use higher and higher group of antibiotics. This is called as escalation. But suppose in a patient you thought that this would be a resistant bacteria and you have initiated a very high level antibiotic. But when the microbiology report comes, the antibiotic is not resistant at all. Then what you need to do? You need to dial down. This is called as de-escalation. Most of the people will have understanding about escalation or de-escalation. Problem is, escalation is easy. De-escalation is not done routine. You should choose the antibiotics based on the site of infections. Whenever you are studying antibiotics, study what is the site of infection, it will be effective, and what it will not be effective. For example, if you find a patient who is having lung infection, you should prescribe antibiotics which are effective in the pulmonary circulation only. Okay. If you do not, what you need to do, you need to give a higher dose of antibiotic. Higher dose of antibiotic means higher chances of resistance. And always go for MIC guided therapy. Okay. So this is the last hospital antibiogram. What is hospital antibiogram? For example, in our hospital, say last 1 year, we have a certain, say, 200 or 300 E. coli isolates. So I have a cumulative data of all the antibiotics which are effective on that. So based on that, what we can see, for E. coli, ciprofloxacin is sensitive only in 25%, whereas for colistin it is 99%. But colistin has many adverse effects. So we need to choose, for example, we can go for amikacin or we can go for piperacillin tazobactam, which have a high level of sensitivity. Okay. Now, if any patient comes with a E. coli infection in our hospital, so we can choose from our hospital antibiotic what should be the empirical drug.